So, good evening, doctor. Myself, Suman from Shield Healthcare. My screen is visible.
No. Yeah, now it is visible.
So, good evening, sir. I, Shuman, on behalf of Shield Healthcare, welcoming you all in today's webinar. And the topic of the today's webinar is management of gestational diabetes mellitus. And our guest speaker is Dr. Sudhanshu Shikharnath, sir. And before moving into the webinar, let's have a look on our Shield Connect page. This is our Shield Connect page. You can find different blogs written by many eminent doctors in different topics in this platform. And these are the past webinars already we have conducted in many topics in our platform. And these are the most important thing, that is our key opinion leaders, and currently 250 to 300 doctors are currently supporting us in this knowledge sharing platform. And this COVID time, it is the most important blog of Shield, that is immunity boosting blog. And these are the PCOS awareness blog. You can find different talks by many eminent speakers in different regional language as well. You can find that is Hindi, English, Malayalam, Telugu, and many more. So I request all the participants to move into that website, as is a very important and informative one. And now it starts to the webinar, and it's my honor to introduce sir. Sir there is MS in obstetrics and gynecology, and sir is the assistant professor in Vimsar, Odisha. With this short introduction, I request sir to take over the session, and meanwhile I request all the participants for their active participation. And once the webinar will be completed, we will have a look on the questions put on the Shield Connect page. So thank you, sir, and over to you, sir. Sir, you are in mute.
Yes. Now, am I audible?
Yes, sir.
Yes.
You can share.
Thank you. Good evening, all delegates present over here. So today's topic is management of gestational diabetes mellitus. So coming straight to the topic, am I clearly audible? Should I start?
Yes, sir. You can start.
Yeah.
You can see.
So introducing gestational diabetes mellitus. It is defined as any degree of impaired glucose intolerance with onset of or fast recognition during pregnancy.
Your screen is not visible.
Slides are not visible. Sorry.
Yes, sir. You have not shared your screen, sir.
Okay. Yes, sir.
Yeah, it's visible, sir.
Yes.
Full screen, sir.
Now I'm doing the slideshow.
Sure. Yeah, great, sir.
So management of gestational diabetes mellitus. Introducing gestational diabetes mellitus, as everybody knows, it is any degree of impaired glucose tolerance, onset or fat recognition during pregnancy. Many are de novo pregnancy induced, and some are type 2 diabetes mellitus. 35 to 40% are type 2, and 10% have autoantibodies against beta cells of pancreas. Coming to epidemiology, this global epidemiology is variable worldwide among different racial and ethnic groups within a country also. In India, the prevalence is 17.7%. The variability is partly because of the different criteria followed and different screening regimens followed all over the world. GDM is an epidemic is unfolding in India. The results from WINGS program, that is Women in India with Gestational Diabetes Strategy, and jointly conducted by the IDF and the MI-DCI Diabetes Foundation, has found four significant features. One is high prevalence, In India alone, GDM affects 5 million women each year. And it's a serious problem because approximately 6 million births in India alone are affected, of which 90% are due to GDM. Then underdiagnosis is the third important picture of this disease. Only half of the GDM patients get tested for GDM. And the confusion prevailing among physicians. Actually, most physicians don't know how to screen despite clear-cut guidelines. When to screen, whom to screen, whether to screening for elective or for all universal. So, Government of India initiatives in regards to GDM is Government of India mandate to screen all pregnant women of GDM. Sorry, issues in its operationalization at the primary healthcare level. Actually, government mandates to screen all pregnant women, but there are many issues in its operationalization of this mandatory screening at primary healthcare level. As per district level household survey 4 conducted between 2012 and 2013, only 59% of government health services are utilized for antenatal checkup. So only 44, according to DLHS 4, only 44% of government doctors employed OGTT to diagnose GDM. Random blood glucose 46%, and fasting plasma glucose utilized in 18% cases, and postprandial glucose, random glucose, utilized by 12% of the doctors, utilized by 12% of the doctors for diagnosing GDM, outside the recommended national guidelines. Coming to pathophysiology of GDM. Most important pathophysiology behind GDM is insulin resistance due to placental secretion of anti-insulin hormone. Almost all hormones secreted by placenta are anti-insulin in nature. Most important out of those hormones is female placental lactogen, and others estrogen, progesterone, and cortisol. All have some degree of anti-insulin-like activity. Next is pancreatic beta cell dysfunction caused by either genetics or autoimmune disorders or chronic insulin resistance. And third is, in late pregnancy, there is overproduction of glucose from maternal hepatic system. In overproduction by 15 to 30% occurs to meet the fetal demand. So combining all these three, insulin resistance due to placental hormones, the pancreatic beta cell destruction, and overproduction of glucose in latter half of pregnancy to meet the fetal demand, combinedly leads to gestational diabetes mellitus. Risk associated with diabetes in pregnancy. Everybody is well known with this risk. Most important maternal risks are preeclampsia, increased cesarean delivery, progression of chronic complications of diabetes. Chronic complications like retinopathy, nephropathy, and neuropathy all progress during pregnancy. Then gestational hypertension and preeclampsia, hypoglycemia, infection, ketoacidosis with type 1 diabetes mellitus, polyhydramnios, preterm labor, everything. Then fetal risks are birth injuries due to macrosomia. In future, childhood obesity, hyperbilirubinemia, hypoglycemia during neonatal period, shoulder dystocia, leading to delivery or cesarean section, respiratory distress syndrome, premature birth, increased cord blood serum C-peptide levels, abnormal birth weight, etc. It is difficult to name GDM when it is developing. Actually, longer periods of hyperglycemia correlates with its complications. Early onset GDM patients compared to late onset GDM patients, there is high rates of perinatal mortality in early onset GDM patients. And neonatal hypoglycemia also with a more incidence, more prevalent in neonates born to GDM patients diagnosed earlier. Next is preterm deliveries. All are increased in case of early onset GDM. Earlier the initiation of treatment, better is the outcome of GDM, and lower is the rates of macrosomia, last for gestational age infants. So as high as 80% of GDM patients may have impaired OGTT right at first trimester, but we usually miss them to diagnose at the peripheral health centers. Screening in second trimester may miss out GDM patients. Usually, patients in peripheral health setup come to doctors in the early second trimester. There can be two answers to this belief. One is universal screening, both in first and second trimester, not to miss the first trimester and also repeat a second test in second trimester. And second is treatment option, treating both, not only for the treatment of prevention of GDM in women with normal OGTT, but also for management of GDM. Treatment for both prevention and management. Coming to concept of fetal programming in GDM. According to this concept, adverse environmental inserts result in environmental insults in during pregnancy may lead to disease in later part of life. There can be two scenarios with overfed state or underfed state. Both overfeeding and underfeeding can program the fetus to develop type 2 diabetes mellitus in later life. In underfed state, underfed state, like maternal starvation, come to overfed state first. In case of overfeeding state, fetal pancreas secretes higher insulin than normal insulin level. So, as this increased insulin secretion occurs, this leads to early beta cell exhaustion. When insulin requirement rises in the latter part, pancreas fails to reciprocate. So, overfeeding maternal state programs the fetal pancreas for insulin overproduction, and that results in exhausted pancreas beta cells to counteract the increased insulin level in latter part of life and developing type 2 diabetes mellitus. Coming to underfed state, for example, maternal starvation. The embryonic pancreas would secrete smaller amount of insulin in the underfed state. The pancreas, which has not completed its organogenesis, it develops a certain level of plasticity. Where due to starvation, pancreas has to secrete lesser amount of insulin, and which the pancreas, fetal pancreas, which has not completed its organogenesis, has to develop some degree of plasticity and loses permanently the capability of producing larger amount of insulin. So when insulin requirement rises, pancreatic beta cells fails to reciprocate again. So concluding, underfed maternal state programs fetal pancreas for insulin underproduction. The fetus grows up with a subnormal capacity to produce insulin, leading to type 2 diabetes. And why don't all pregnant women develop GDM? During pregnancy, a woman develops insulin resistance mainly due to hormone production by placenta, which antagonize insulin action. But still, she won't develop GDM. Everyone won't develop GDM, as the pancreas has enough functional reserve to counter this insulin resistance. But in some women, insulin action is already at a lower level, and pancreatic reserves are lower. Although they are not diabetic to start with, such women are not able to handle the rise of insulin resistance due to pregnancy, resulting in GDM. The placental hormones, insulin resistance occurs after delivery, placenta is removed, placental hormones are withdrawn, and normal insulin resistance returns back. This should be the normal phenomenon. But in GDM patients, what occurs? Pancreatic reserves are lower. Women with history of GDM may have up to a 60% likelihood of developing GDM in future pregnancy. The main reason for this high probability is that as time goes by, functional reserves of the pancreas are reduced. Screening for GDM with 75 gram oral glucose tolerance test. 75 gram glucose is taken irrespective of previous meal status, and the criteria taken as per American Diabetes Association is fasting sugars cutoff is more than equal to 95 milligram per deciliter, 1 hour 180 milligram per deciliter, and 2 hour cutoff is more than equal to 155 milligram per deciliter. But as per WHO, fasting remains the same, 95 milligram per deciliter, but a single value at 2 hours is taken as 140 milligram per deciliter as cutoff for diagnosing GDM. 75 glucose challenge test, which is single glucose, plasma glucose at 2 hours, If it is more than 140 milligram per deciliter, it is GDM, no doubt. If it is more than equal to 120 milligram per deciliter, but less than 140, it is decreased gestational glucose tolerance, TGGT. So universal screening done in the first trimester, if negative, repeated at 24 to 28 weeks, and then again repeated at 32 to 34 weeks. National guidelines by Ministry of Health and Family Welfare, Government of India says every pregnant woman in community should be tested for GDM at the first antenatal visit with 75 gram oral glucose with 2-hour plasma glucose value. If it is more than 140 milligram per deciliter, it is managed as a case of GDM as per guidelines. And if it is negative, that is less than 140 milligram per deciliter, then repeat testing should be done at 24 to 28 weeks. Again, if it comes as positive, more than 140 milligram per deciliter, it is managed as a case of GDM. And if it is negative, it is managed with normal antenatal checkings. Issues in management. Issues in managing a case of GDM. Number one is patient education. Patients should be educated regarding the GDM. She is not having diabetes before, but she is having gestational diabetes mellitus, which can adversely affect her baby and herself. Medical nutrition therapy, which is easy to advise but difficult to follow. Next is pharmacological therapy with oral hypoglycemic agents and insulin. Next is glycemic monitoring, self-monitoring of blood glucose and targets. Then fetal monitoring with ultrasound, and planning and delivery. When to deliver, what time to deliver, and how to deliver, how to deliver more than 4.5 kg baby or macrosomic baby. ACOG has not given a clear-cut guideline. The goals are to achieve normoglycemia, to prevent ketosis, provide adequate weight gain, and contribute to fetal well-being. And there should be some nutritional plan, calorie allotment, calorie distribution, and carbohydrate intake. Calorie allotment per day, how much calorie to be taken, and calorie distribution, how much energy calories should be obtained from protein, fat, and carbohydrates, and which carbohydrates to take. Coming to calorie allotment. For pregnant women whose BMI is between 22 to 25, normal range, they should take 30 calories per kg per day. But when BMI is 26 to 29, pre-obese, they should take 24 kilocalories per kg per day. They are overweight. And when BMI is more than 30 or morbidly obese patients, the morbidly obese pregnant women, calorie intake should be restricted to 12 to 15 kilocalories per kg per day. And for underweight women, BMI less than 22, calorie intake should be 40 kilocalories per kg per day. Now, carbohydrate intake. Postprandial blood glucose concentration can be blunted if the diet is carbohydrate restricted. Complex carbohydrates are less likely to produce significant postprandial hypoglycemia. A randomized crossover study found that liberalizing complex carbohydrates intake in GDM women resulted in an achievement of glycemia below target levels and lowered the postprandial free fatty acid concentration also. So, complex carbohydrates containing food like the starches and vegetables are recommended. Carbohydrates intake is restricted to 33 to 40% of the calories, with the remainder divided between protein and fat. From protein, it should be 20%, and from fat, it should be 40%. So with this calorie distribution, 75 to 80% of women with GDM will achieve normoglycemia. Coming to glycemic targets by ACOG. ACOG says fasting venous plasma should be less than 95 milligram per deciliter. 1 hour postprandial blood sugar should be less than 140 milligram per deciliter, and 2 hours it should be less than 120 milligram per deciliter. These are the targets. Pre-meal or fasting blood sugar should be less than 100, and HbA1c level should be lesser than 6%. But American Diabetes Association says pre-meal or fasting blood sugar 80 to 110, it is okay. 2 hour post-meal, not more than 155. These are venous plasma targets. not glucometer regulates to remember. Coming to pharmacological intervention for GDM. If the fasting plasma glucose diagnosis is more than 120, can consider immediate therapy. Otherwise, multi-nutrient, medical nutrition therapy for 2 weeks. If majority of fasting plasma glucose 4 times out of 7 times tested is more than 95 or postprandial is more than 120, then to start insulin immediately. Current treatment regimens is like this: metformin, insulin, and inositols. Metformin, every treatment has some pros and cons. Coming to metformin, it attacks insulin resistance. Wide experience is there of using metformin in GDM patients. And cons are, it does not prevent GDM. It cannot manage severe cases. It is not tolerated by all. It crosses placental barrier, though it has not shown any risk, fetal risk, teratogenic risk, but it crosses placental barrier. Categorized by USFDA as category B. Insulin, it is very much efficacious. Cons are, it is injectable, hypoglycemia incidences are very frequent, weight gain is there. Large for gestational babies are more with insulin taking women and unable to prevent fetal complications of GDM. It does not tackle the root cause. Then the third option, inositols, myoinositols and D-chiroinositols. The pros are both prevent and manage the GDM. It attacks the root cause of GDM. It leads to favorable fetal and maternal outcomes, shown to be superior to metformin, safer than both drugs, insulin and metformin. As it is a dietary supplement, it is safer to use and better than insulin and metformin with regard to its safety profile. Cons are its limited usage experience. No randomized control trials and large studies has come out yet to prove its beneficial effects in treating and recommending these inositols to treat GDM. So limited investment research and education by pharma industry takes time to show results. Confusion also exists in terms of dose and formulation, although data is straightforward. Coming to insulin, almost 25 to 50% of GDM patients need some pharmacotherapy, out of which around 15% need insulin. Total dose varies 0.7 to 2 units per kg. If fasting blood glucose is high, but that is isolated fasting hyperglycemia, some cases are managed with single bedtime NPH insulin at the dose of 0.2 units per kg. But if the fasting blood glucose is high and postprandial hyperglycemia is also observed, so 1.5 units per 10 gram of carbohydrates after breakfast, 1 unit per 10 gram of carbohydrates for lunch and dinner taken. Multiple daily dosing should be taken for both fasting and postprandial blood sugar higher level. If both pre and postprandial blood glucose are higher, if women's postprandial glucose levels can only be blunted if starvation ketosis occurs, 4 injection per day regimen is followed usually. NPH insulin is in the morning and bedtime, along with rapid acting insulin to cover mealtime elevations. Other rapid acting insulins like Lispro, Aspart. The total dose should be 0.7 unit per kg up to 18 weeks of pregnancy, and 0.8 units per kg for weeks between 18 to 26. Next is 0.9 units per kg for weeks 26 to 36, and after 36 till term, 1 unit per kg is followed. During delivery, it may be 1.1 to 1.5 unit per kg. Coming to oral hypoglycemic agents in pregnancy, systematic review by Johns Hopkins University has concluded maternal glucose levels did not differ substantially between GDM pregnancies treated with insulin versus those treated with oral glucose lowering agents. There is no consistent evidence of an increase in any adverse maternal or fetal neonatal outcome with use of glyburide, acarbose, metformin compared with the use of insulin. There is inconsistent data. by ADA, SCOG, USFDA, which do not endorse its direct use in GDM prevention or treatment. At present, that are insufficient as to recommend any oral agent other than glyburide or metformin. Coming to tolbutamide and chlorpropamide, these cross placenta fetal hyperinsulinemia, prolonged fetal hypoglycemia occurs. Glibenclamide or glyburide is just minimal transplacental transport. Observational studies show no excess anomalies or hypoglycemia. Only RCT consisting of 404 women has shown glibenclamide versus insulin has shown no difference between these two in treating GDM. Second generation sulfonylurea, especially glyburide, do not significantly cross placenta, but its failure rate is 15 to 20%, requiring a changeover to insulin. Fetal concentrations are only 1 to 2% of the maternal concentrations found. Tolbutamide crosses placenta most freely, followed by chlorpropamide, glipizide, and glyburide at the least. Glyburide being the least. Metformin crosses placenta, but no teratogenic effect has been seen in rat models. So metformin is a category B drug. No adverse outcome after first trimester. In second and third trimester, it is safe and effective. And against insulin, when it is evaluated, there is no serious adverse effects noted. But limitation is no studies in there is no study or lesser studies as they are, including metformin versus glibenclamide or glyburide. Coming to inositols. Inositols are members of inositol family regulating insulin signaling. Myoinositol and D-cheiroinositol are the most important members of this inositol family. These are called the gatekeepers because these act as gatekeepers on insulin signaling and glucose metabolism. Myoinositol further causes is necessary for translocation of glucose transporter to the cell membrane. It regulates glucose cellular uptake. And D-cheiroinositol stimulates pyruvate dehydrogenase, which is an active enzyme in the Krebs cycle, necessary for ATP production. So these myoinositol and D-cheiroinositol, when given in recommended dose, recommended fixed combination, it stimulates insulin secretion from pancreatic beta cells. All these effects take place when myoinositol and D-cheiroinositol are present at the physiological ratio of 40:1. Myoinositol in GDM, study 1. First study which was conducted in 2013 by Diana et al. Pregnant women with family history of type 2 diabetes mellitus 197 in number were taken. They are divided into two groups. First group of 99 women given 4 grams of myoinositol and 400 micrograms of folic acid. And group B, second group, is given only 400 micrograms of folic acid. So they were compared these two groups, where they found GDM rate was 80% lesser with MI or myoinositol compared to control group. And macrosomia rate, there was no macrosomia, no case of macrosomia in women taking myoinositol. Another study, a randomized control trial in 2011, myoinositol and insulin resistance in GDM. GDM patients are taken 69 in number. They are divided into two groups. First group was given 4 grams of myoinositol plus 400 micrograms of folic acid, and second group also given only 400 micrograms of folic acid. 8 weeks therapy was continued and then studied. The result was like this: fasting glucose was 40% better decrease in fasting glucose with women taking myoinositol, and 60-80% better decrease in fasting insulin with myoinositol taking women. 74% of reduction in insulin resistance with myoinositol, and 449% higher surge in adiponectin levels. Adiponectin is a protein secreted from adipocytes. Ionocetal therapy in GDM substantially lowers complications of GDM. What ionocetal means to GDM? A meta-analysis 2015 by Zheng et al. They say ionocetal has capacity to decrease the incidence of respiratory distress syndrome, preterm delivery, macrosomia, shoulder dystocia, neonatal hypoglycemia, polyhydramnios, etc. Similar conclusion also reached by a Cochrane group. And summary says, although the evidence is based on 4 small trials, 3 published trials, and a conference abstract, it appears that myoinositol shows promise in reducing the risk of gestational diabetes. The recommendation finally, in prenatal care, there should be health education to explain that GDM will respond to changes in diet and exercise. Oral blood glucose lowering agents or insulin therapy if diet and exercise do not control. If GDM not detected and controlled, a risk of serious adverse health birth complications such as shoulder dystocia may occur. Diagnosis of GDM will lead to increased monitoring and intervention. Medical nutrition therapy in GDM to support pregnancy based on the guidance from dietary reference intake. It should be dietitian or nutritionist should provide adequate micronutrients. Physical activity level, GDM should be diagnosed at any time during pregnancy if one of the following criteria are met: following 75 oral glucose load, fasting glucose 5.1 to 6.9 millimole per liter, 1 hour plasma glucose more than equal to 10 millimole per liter, and 2 hour plasma glucose 8.5 to 11 millimole per liter. Pharmacological therapy for women who are not adherent to or who refuse insulin, glyburide, or metformin may be used as alternative. Blood glucose monitoring. Do not offer continuous glucose monitoring routinely to pregnant women with diabetes. Coming to intrapartum care, discuss the timing and mode of work with the pregnant woman with diabetes during antenatal appointments, especially during the 3rd trimester. Glycemic control. Women should be closely monitored during labor and delivery, and maternal blood glucose levels should be kept between 4 to 7 millimoles per liter in order to minimize the risk of neonatal hypoglycemia. In neonatal care, neonatal hypoglycemia, measure the infant's plasma glucose as 1 to 2 hours of age, again at 4 hours, and then 4 hourly before feeds until there have been 3 consecutive readings more than 2.6 millimole per liter. Initial assessment, carry out blood test for polycythemia, hyperbilirubinemia, hypocalcemia, hypomagnesemia, which are more common in case of GDM patients, neonates delivered to GDM patients. Then recommendations for postpartum care. Blood glucose control, women should be encouraged on breastfeeding. They can resume or continue the taking intake of metformin and glucosamine immediately after birth as required, but should avoid other forms of oral hypoglycemic agents while breastfeeding. Only glyburide or metformin. Information and follow-up. Women should be informed about the increased risk of future diabetes mellitus and hyperglycemia in future pregnancy also, and should be offered lifestyle advice, including weight control, diet, and other exercise. Postnatal blood glucose testing. So GDM patients should be offered a postnatal test at 6 to 12 weeks to exclude DM for and again it is repeated every 3-hourly interval as per American Diabetes Association. First at 6 to 12 weeks and again repeated at every 3 yearly. Thank you.
Thank you very much, sir, for this nice presentation. And meanwhile, I received few questions. So if you allow me, then I can move with that.
Yeah.
Yes, sir. So, sir, the first question is, what is the ideal dose of insulin in case of GDM?
Sorry?
What is the ideal dose of insulin in case of GDM?
Ideal dose I've already described according as per the gestational ages up to 8 unit, starting from 0.7 unit per kg to 1 unit per kg body weight. And during labor, it may increase up to 1 to 1.5 unit per kg body weight.
Okay. And another question, sir. What will be the treatment approach in case of polyhydramnios in case of GDM?
Polyhydramnios is diagnosed when AFI, amniotic fluid index, is more than 24. Okay. Also, it is mild. Up to 30, AFI 30 centimeter, it is mild. So there's you should not be worried about association with congenital anomalies. So more than 30 AFI are more associated with fetal anomalies. So we can give endomethacin and controlled leaking, controlled ARM during labor, controlled ARM, and vaginal delivery if possible. If expected birth weight is more than 4.5 kg, you should prefer cesarean section.
Okay, sir. And sir, do you recommend any kind of exercise during that gestational diabetes?
Exercise is very much essential. Up to 30 to 45 minutes exercise in form of mild walking, normal walking, at least for 40 minutes a day, and preferably after meals, will be helpful in controlling the postprandial rise of blood sugar levels. Okay.
And sir, Dr. Lakshmi Reddy asked one question, sir, regarding steroids antenatally, whether it has any effect or some disadvantage. What is your opinion?
Steroids.
Yes, sir.
Steroids for lungs maturation, fetal lung maturation.
Yes.
Usually, babies with fetus with mothers with diabetes, gestational diabetes or over diabetes, they need not take these steroid for lung maturation. Already cortisol secretion is more in those neonates, fetus with diabetes and IUGR babies also.
Okay, sir.
But if you give also, it has no any not conditions. Yeah, next.
Okay, sir. And one question, sir, means if means it is very related to this time, as if you found a patient with COVID positive and with GDM. So, is there any difference in the strategy to combat this GDM in COVID patient? Is there any changes out there?
There should be not any special because except only and only most important thing is control. Keep the blood sugar level within control. Okay, keep the blood sugar level within control and treat COVID-19.
So, sir. And is COVID hampers this diabetes? What is your practical opinion, practical observation on that?
Yeah, any type of stress raises glucose level in body. For COVID-19 or any other disease, for hospitalization or any surgery that raises hyperglycemia, causes hyperglycemia. But COVID-19 itself causing hyperglycemia is not studied yet. Few studies say that it affects beta cells and decreases insulin secretion, COVID-19, and causes diabetes. But this at this point of time can't say.
Sir, another question: what will be the first preference? Means the first dosage regimen preference for GDM in first 3 months.
First 3 months is insulin.
Sorry, sir.
Insulin.
Okay, insulin. And means another question, sir. What is the means your approach in terms of using inositol in case of GDM? Yes. What is your observation on that?
Yes, we actually whatever dose we give 1:40 ratio, inositol and decarbonyl, these are all physiological state. So treating a patient with GDM or preventing GDM, giving with a physiological fixed dose combination of myoinositol and bicarbonate is not has not been studied yet. But what is helpful? It's helpful from all the studies I have shown in the slides. They clearly shown macrosomia. There is no case of macrosomia with the patient treated with MI-DCI. So some benefits there, but it will take further studies, larger studies to conclude and recommend by recommendation by FDA and ACOG.
Okay, sir. And one appreciation from Dr. Pradeep Simha. Sir told that it's a good presentation, and I could not
Thank
find
you very much.
I could not find any other question.
Yeah.
So if you allow me, then we can conclude this webinar session here, sir.
Thank you.
So thank you
Thank
very
you.
much, sir, for your valuable time once again in our platform, and in the future
Yeah.
also we will
Thank
look
you.
forward from your
And
valuable
all
time.
the delegates present over here and giving me a platform to speak about this burning issue and the newer drugs. Thank you very much.
Thank you very much, sir. Thank you. Good day, sir.